Welcome to CE on ReachMD. This activity is provided by Medtelligence and is part of our Minute CE curriculum. Prior to beginning the activity, please be sure to review the faculty and commercial support disclosure statements as well as the learning objectives.
This is CE on ReachMD, and I'm Dr. Dana Rizk. Here with me today is Dr. Zhang, and our topic today is unmet clinical needs in IgA nephropathy. Dr. Zhang, we have real-world and registry-based evidence from China and Japan that demonstrate the frequent failure to achieve guideline-recommended proteinuria targets with standard of care alone. Can you elaborate on this information for us?
Thank you, Dana. So that a standard of care-based comprehensive strategy centered on the optimal RAAS inhibitor that is fundamental to prevent IgA nephropathy progression and related complication. However, the real-world and registry-based evidence from China and Japan consistently highlight that the standard of care alone is often insufficient to achieve guideline-recommended proteinuria target. The data from China National IgA Registry, that's a very big sample size, is over 3,000. That indicate that 40 to 60% of patients on maximal tolerated RAAS inhibitor still have proteinuria over 1 gram per day after 2 years follow-up. And a subset even have proteinuria, that patient have proteinuria over 2 gram per day. They are associated with 3 to 5-fold higher ESKD risk over 5 to 10 years. So that's Chinese data. And regarding Japanese data, that's also found that Japan's IgA registry and that's a regional cohort report similar trends. That's 35 to 55% of patients on optimal RAAS inhibitor do not achieve proteinuria less than 1 gram per day. And it's also noticed that up to 20% of those with initial partial response, that means the proteinuria reduction over 30%, they also experience a rebound within 3 years. So that's underscoring RAAS inhibitor limitation in long-term disease control. I think that's information. So per KDIGO guideline, systemic corticosteroids is an option for high-risk progressive IgA nephropathy patient based on the testing trial that confirm its efficacy in reducing proteinuria and delaying ESKD. However, the safety concern and the patient barriers, especially in younger patients, limiting its clinical application. So patients treated with corticosteroids have to face higher steroid-related adverse events and a lifetime risk. So that means there are a lot of unmet need. Fortunately, more recent years, new agents such as atrasentan, sparsentan, Nefcan, as well as epitacopan, were approved in IgA nephropathy treatment. I think that has improved the situation of lack of novel agents for clinical treatment of IgA nephropathy.
Yeah, and I think not achieving guideline recommended proteinuria level may be even more dramatic now that the proteinuria recommendation is to reduce it to less than 0.5 gram per day. So it's going to be really quite hard for these Asian populations that you just described.
Yeah, I think that's IgA nephropathy is a kind of immune-mediated chronic progressive glomerular disease, and that's like as a immuno mediated chronic disease. That's per KDIGO guideline. It managed require due targeting of disease specific driven of nephral loss and the system response to IgA nephropathy induced the nephron injury. So that's a comprehensive approach that's incorporating novel agent testing, pathogenesis-based clinical trial, bring new prospect for our patient.
Yeah, absolutely. So patients are going to need more than one drug to do so. So with that, our time is up. Thank you for a great discussion, Dr. Zhang, and thanks to our audience for tuning in.
Thank you.
You have been listening to CE on ReachMD. This activity is provided by Medtelligence and is part of our Minute CE curriculum. To receive your free CE credit or to download this activity, go to reachmd.com/CME. Thank you for listening.